Hello and welcome to today's webcast, Pregnancy and Psoriatic Disease, What to Expect. My name is Bev Bromfield and I will be your moderator for today's presentation. Before we start, I'd like to go over a few items so you know how to participate in today's event. We've taken a screenshot of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. You've joined this presentation using your computer speaker system by default. This means if you hear music through your computer, you should be able to hear the presentation. If you prefer to join over the telephone, select Use Telephone in the audio pane and the dial-in information will be displayed. You'll have the opportunity to submit questions to today's presenter by typing into the questions pane on the control panel. You can send your questions in at any time during the presentation. We'll collect these and address as many as possible at the end of Dr. Porter's presentation. Before I provide information about the foundation, I'd like to acknowledge our sponsor, UCB, for helping to make today's presentation possible. Their support on behalf of the Pregnancy and Psoriatic Disease webinar, What to Expect, is sincerely appreciated. Since some of you may be new to the foundation, here's a little background about who we are, our mission, and what we do. In 2014, the National Psoriasis Foundation developed a strategic plan which drives everything we do as an organization. To achieve our mission, the following goals were identified: accelerate discovery to cure psoriatic disease, improve health outcomes, achieve goals to help reach our mission, whether it's being involved with an event or becoming a volunteer. By attending today's program, you've already taken a step towards expanding your knowledge about psoriasis and psoriatic arthritis and a better understanding of what it means to live with psoriatic disease. If you have psoriasis or psoriatic arthritis, you can help accelerate efforts towards a cure and a greater understanding of the disease by participating in the NPF Corona National Psoriasis Patient Registry, which is the largest independent observational registry of psoriasis patients in the U.S. This registry represents a network of dermatology clinics that collect and study patient health information, allowing researchers to compare the safety and efficacy of psoriasis treatments, better understand conditions that are related to psoriasis, and explore the history of the disease. You can share your experience with researchers about what it means to live with psoriasis and psoriatic arthritis by participating in Citizen Scientist. Answer questions and view your data along with over 4,000 participants. Data is used to help researchers gain a better understanding of the disease. To learn more and participate, visit the websites listed on the screen. We continue to improve health outcomes through our Patient Navigation Center, the world's first personalized support center for people impacted by psoriatic disease. The Foundation's Patient Navigation Center is available to help you find physicians, treatment information, navigate insurance issues, access support through our one-to-one program, and more. Contact us at 1-800-723-9166 or visit psoriasis.org/navigation center. To achieve the Foundation's goals as mentioned, please support our mission through donations or by participating in local Team NPF events near you. You can learn more at psoriasis.org/donate or teamnpf.org. On behalf of the National Psoriasis Foundation, thank you for attending today's webinar, where you'll learn more about what to expect with psoriasis and or psoriatic arthritis when planning for pregnancy, during and postpartum care, what treatment options and considerations impact decisions when planning for pregnancy, during and postpartum care, resources to help gain a better understanding of pregnancy, psoriatic disease, and available treatment options. I'd now like to introduce you to our speaker, Dr. Martina Porter. Dr. Porter is a board-certified dermatologist who is the co-director of the Clinical Laboratory for Epidemiology and Applied Research in Skin, also known as CLEARS, with the Department of Dermatology at Beth Israel Deaconess Medical Center in Boston. Additionally, Dr. Porter holds a faculty appointment as an instructor of dermatology at Harvard Medical School. Dr. Porter has authored several articles about pregnancy and psoriasis, including use of biologics in pregnancy, limitations stemming from clinical trials and registry experience, which was just published in March, in the Journal of the European Academy of Dermatology and Venerology. She has previously written articles about the safety of biologics during pregnancy. It is my pleasure to welcome Dr. Porter, who will provide the latest information around pregnancy and psoriatic disease, what to expect. Please welcome Dr. Porter.
Thank you. These are my disclosures, but I'm very excited today to give this presentation. I actually have many patients who have psoriasis, and I receive a lot of referrals from other dermatologists and physicians as well for treatment of psoriasis patients. And pregnancy, I think, is one of the most difficult times to offer treatment to patients with psoriasis. So I'm really excited to do this webinar today. But here's a list of the most common questions that I receive from my patients who are either considering pregnancy or who are pregnant and who have psoriasis. And these include questions like, can I take my psoriasis medications when I am pregnant or planning to get pregnant? Can I breastfeed while I'm on my psoriasis medications? Will my psoriasis get worse during pregnancy? Are there any special consideration for males who want to have a child through pregnancy? And the other question we get is, will my children have psoriasis? And I'll try to answer all of these today. And at the very end, we also have a Q&A session as well. So feel free to send in your questions and we'll try to address as many as we can. So just for background, in the United States, we have about 6 million pregnancies per year. Many women take medications while they're pregnant. 90% of them take one medication, and about 50% take 4 or more medications. Many pregnancies in the United States are also unplanned, and so that's why we like to talk about what can you do while planning for pregnancy, but also what do you do if you find out that you're pregnant and it wasn't planned and you're on your medications. What are the real risks that are associated with your disease and the medications that you're taking? And the other thing that we know now is women are getting pregnant later in life, and this has an impact on a lot of things related to psoriasis disease management. One is that they know the older you are, once you kind of hit the age of 28, it becomes more difficult to get pregnant. And they've always classified women over the age of 35 as advanced maternal age pregnancies, and they consider these patients to be higher risk as well. And so what we're finding, and there was actually a very good New York Times article about this many months ago, is that women who are in areas that are very metropolitan and have more advanced degrees tend to get pregnant later. And so the window they have to actually get pregnant and have a successful pregnancy are much smaller than they were like 50 years ago when women got pregnant at an earlier age. And then when we see these patients in the office, there's less time to really plan things and they have more questions about what they can do. And then the other thing to note about pregnancy is that the risks are very different between the trimesters. So patients who get pregnant in their first trimester, which is the first 3 months of pregnancy, this is when most of the significant fetal development occurs, and we call it a period of organogenesis, where all your baby's internal organs are developing during that time. Whereas towards the third trimester, the baby is pretty much fully developed, or what we like to say, almost fully cooked, and there may be less risk to these babies being exposed to medications because it's not going to affect the development of their organs. And so what do we know about psoriasis in pregnancy? The first thing is that the average age of female patients at the time of onset of psoriasis is about 28 years. And that means that this is a peak age of fertility, and women tend to develop this disease right when they're also planning or about to have children. We also know that women with psoriasis appear to get pregnant less often compared to patients who don't have psoriasis, and that women with psoriasis have other important comorbidities that may increase their risk of having adverse pregnancy outcomes or miscarriages. And we also know that about 1/3 of people with psoriasis have a family member with disease. And so this means that if you have psoriasis and you have a child, your child is not guaranteed to have the disease. But the other thing we do know is that patients that have a family history of psoriasis tend to develop the disease earlier in life than patients who do not have any family members with psoriasis. So here's a list of all the different comorbidities that are associated with psoriasis, and you can actually find this out on our American Academy of Dermatology website. But some of these risks are important to note because they also are independent risk factors for having negative birth outcomes in pregnancy, and specifically diabetes, metabolic syndrome, cardiovascular disease, and depression may increase the risk of negative birth outcomes, and these are comorbidities that are found in patients who have psoriasis. Additionally, they've had a study where they looked at patients with psoriasis, and they found that they were more likely to smoke in the first trimester of pregnancy, more likely to be overweight, again, more likely to have a history of depression compared to patients who had no autoimmune diseases. And they were also less likely to use prenatal vitamins or folate supplementation at the time of conception. And those are very necessary vitamins for children's babies' development in the first trimester because they need them to develop their nervous system and all of their nerves, including their spinal cord. And what happens in any pregnancy is we see a lot of physiologic changes to the mother's immune system. So we say pregnancy is marked by this complex maternal hormonal and immune system change. The most significant immune system shift that we see is a change in a type of white blood cell called a Th1 or a T helper cell 1 that shifts to actually a T helper cell 2 response. And this is really significant for some autoimmune diseases like multiple sclerosis that are driven entirely by these Th1 responses, that patients actually experience disease remission when they get pregnant. Psoriasis is also thought to be along this pathway where most of the Th1 cells are the T helper cells are Th17, but there's also some Th1 involvement. And therefore, when we see this shift from Th1 to Th2, most patients in pregnancy have some disease improvement because there's downregulation of these Th1 cells. This is theoretical, but in practice, what do we actually see during pregnancy and postpartum? Approximately 50% of patients improve in terms of their psoriasis disease severity while they're pregnant. But that means that an equal number of patients either have no change in their disease, so it stays the same pre-pregnancy, during pregnancy, versus having worsening of disease during pregnancy. But what we do know is regardless of if you've improved, stayed the same, or worse during pregnancy, is that the majority of patients with psoriasis report immediate postpartum disease flares, and this usually occurs in the few months after delivery. And one of the other things that we see is some patients who have C-sections or cesarean sections, because there's a cut to the skin, they develop something called chemnorization, which is the development of the psoriasis or any other skin disease in the area that was traumatized. And so if you look at the pictures here, this is not a C-section, but you can imagine that if you have a big cut across your abdomen, you may actually develop disease there as the skin is healing as part of the healing process. But what do we know about psoriasis in pregnancy? One of the things that we do notice is that there are a lot of missing data points for pregnant women who are needing treatment with any disease. And in psoriasis, it's no different than it is in multiple sclerosis, for example. And there's been a big push in the medical community recently, and you can see there's an article here from August 2018 that was a perspective that talked about the barriers of including pregnant women in clinical trials, because essentially when we develop all of the new drugs that are coming out for psoriasis or for other diseases, almost every single clinical trial that tests these drugs excludes women who are pregnant, planning to become pregnant, or nursing. And so we don't have enough data from those trials to be able to extrapolate and say, oh, this drug is safe or not, because there were no patients in the study that actually received them. And so then we have to wait essentially to get data either from patients who accidentally become pregnant unplanned during the trials, or if we get information after the drug is approved, either through registries or people reporting any sort of issues that happened while they were on the drug. And even in this sense, we get a bias because we really only hear a lot of reports about bad outcomes, and we don't really get reports on patients who had a normal pregnancy after exposure to a drug. And one of the articles that we published recently was called Use of Biologics in Pregnancy, Limitations Stemming from Clinical Trials and Registry Experience, is that even in studies where we're just following patients over time, where there's no intervention and no medications given, we're just tracking them, we find that there are not as many pregnant women or women of childbearing potential participating in these studies compared to just men, for example. And the one thing that we really should also focus on too is, does psoriasis affect pregnancy outcomes independent of what medication you are receiving as treatment for your disease? So in 2016, there was this article published here that says Psoriasis and Adverse Pregnancy Outcomes, a systematic review of observational studies. And this article actually looked at 9 different studies that had been published in the literature about psoriasis and pregnancy, and they found overall there was no clear evidence of increased adverse outcomes in pregnant women with psoriasis. However, if you go and look at the data, 4 of the 9 studies did show some increased risk in at least one adverse or negative outcome, including spontaneous abortion, the need for a C-section, low birth weight, large babies that were large for gestational age, or prematurity. And if over time we actually have come to think that pregnancy outcomes are generally thought to be poorer in patients who have psoriasis, and we think that this is because of the inflammation. And psoriasis is not limited to just the skin. We know that it's systemic inflammation and it may cause immune system dysregulation, but we have so many difficulties interpreting the data because some studies will have conflicting data where one will show poor pregnancy outcomes like preterm birth, low birth weight, recurrent miscarriages, and increased cesarean section deliveries, and others will say the complete opposite. So right now, it's a little bit difficult to exactly estimate what the risks are of just having psoriasis with pregnancy, but the most recent studies are starting to show that pregnancy outcomes may be worse. And this is something that we do see in other inflammatory diseases like inflammatory bowel disease, which is Crohn's disease or ulcerative colitis, and also rheumatoid arthritis. And we get to talking about treatments because these diseases are actually treated with very similar systemic and biologic agents to psoriasis. When we look at the guidelines that both gastroenterologists and rheumatologists have put forth for the inflammatory bowel disease and rheumatoid arthritis populations, we can see that they're a little bit different than what is being done for psoriasis. So this is a study that looked across a population cohort, meaning all the patients that were in Denmark and Sweden, and they found there were about 8,000 births in 6,000 patients who had psoriasis. So some women had multiple children during this time period. And then they also had a small subset of patients who had psoriatic arthritis. But what they found was that there was an increased risk of gestational diabetes, hypertension, preeclampsia, elective and emergency C-sections, and women who had psoriasis or psoriatic arthritis. And they found that the risks were higher for women with severe psoriasis. And they had an increased risk of preterm birth and low birth weight. And this kind of matches what we think, that the more inflammation you have, the more likely it is that if you were to experience a negative effect of pregnancy, it would be in someone who has more severe disease compared to mild disease. And this helps us figure out if somebody should be treated or not. But just for reference as we go forward, it's good to know that the major birth defect rate of any pregnancy in the general U.S. population is 2 to 4%, and some estimate 3 to 5%. So that means that up to 5% of pregnancies, regardless of if the patient has psoriasis or is being treated with any medications, there is a risk of major birth defect, and that the miscarriage rate can be up to 20% of the population for the pregnancy. So it's actually quite high. And when we go and look at the numbers for all the different treatments, it'll help you compare what the risk is of those treatments to the risk of the overall population. And like I said before, women over the age of 35 are considered advanced maternal age. And these women who also have psoriasis had significantly lower pregnancy rates and live birth rates compared to patients without psoriasis. So does psoriasis affect my ability to get pregnant? The short answer is we don't know if psoriasis impacts fertility. There have been some observations that there is a link between psoriasis and infertility. It may be related to the fact that women are older age when they tried to get pregnant, but they did find that there was a small study where they had an increased prevalence of PCOS or polycystic ovarian syndrome in psoriasis patients, and this is one of the major causes of female infertility in general. And then for males, there was a small study that had been identified impaired fertility in untreated male psoriatic patients and suggested that the systemic inflammation from psoriasis altered hormonal profiles in these men, and then they were less likely to be able to father children. And then anecdotally in our clinics, we've encountered a substantial number of women with psoriasis who have had to undergo IVF treatment in order to get pregnant. So these are the general treatment options that we have for psoriasis, regardless of if you're pregnant or not. We know that everything has advanced tremendously over the past 15 years, and we've seen many new great medications come to market. And now we can really control psoriasis quite well, but we still don't have a cure. And any therapy that you choose should really be a decision that's made with your input and your doctor's input. And I would really strongly advocate for you as a patient to explain to your doctor what you feel comfortable with and what you don't feel comfortable with and why. So for people with mild psoriasis, which is here categorized as less than 3% of your body surface area, which means 3 palm prints. So each palm print is equivalent to 1% surface on your body. And these patients who have mild psoriasis, again, less than 3%, are usually treated with topicals or phototherapy or both. And they may get more aggressive treatment, meaning a systemic medication, something that you either take orally or you inject, if you have less than 3% of your body surface area affected, but it's in a very sensitive area, such as the hands, the feet, the face, the scalp, or the genital area. The next category of patients is moderate to severe, and moderate is considered 3 to 10%, and severe is considered more than 10% of your body with psoriasis. So for these moderate to severe patients, we generally recommend stronger or more aggressive treatments, and the ones that we really tend to recommend are biologics, oral treatments such as methotrexate, acitretin, cyclosporin, apremilast or Otezla, and then phototherapy or a combination of these plus topicals. Topicals alone are usually not effective enough to manage moderate to severe psoriasis because of the amount of cream that you need and the number of applications that would be required per day. And in 2013, there was a study that looked at the number of patients that were on TNF-alpha inhibitors. So at that time, it would be medications such as Humira and Enbrel, or adalimumab and etanercept are their other names. And they found that approximately 25% of patients with psoriasis were treated with biologic agents, which is a good number of patients. So how do the treatment options change with pregnancy? Treatment during pregnancy is a very personal choice. And it doesn't just include medication. It also includes food and alcohol, because there are many recommendations that your OBGYN will give you about foods to avoid, alcohol because of all the risks that could be associated with either infection or development difficulties, primarily in the first trimester for mothers and their babies. But there's a lot of pressure on women to breastfeed and to avoid all of these medications, because if anything were to happen, the last thing you want would be to attribute it to something that you exposed your baby to. And when we went back and looked at how many of pregnancies results in either miscarriage, which I showed you before was 15 to 20%, or to having some sort of birth defect, which was up to 5%, that's a high enough number that if you would expect that like up to 1 in 5 of your, or 1 in 20 of your friends who got pregnant could have a problem with their pregnancy. One of the special considerations that psoriasis patients have to deal with is that many other physicians consider psoriasis to be cosmetic or trivial. And they say, oh, it doesn't matter if you don't treat your psoriasis during pregnancy because you can just get back on the medications afterwards and it will go away again. Psoriatic arthritis is a little bit different, because if you leave it untreated, it can lead to irreversible joint damage. But when I've talked to personally some of our high-risk maternal fetal medicine obstetrics and gynecologist colleagues, they actually say, oh, for psoriasis, I never recommend treatment with certain systemic medications because the patients shouldn't put their babies at risk. It's just skin disease. And I think that's one of the things that we battle frequently as dermatologists is helping other physicians understand that having a skin disease can have a significant impact on your quality of life too. And a lot of times in general with pregnancy, regardless of if a patient has psoriasis or not, patients and physicians are very reluctant to treat the disease because they just don't know how much impact it could have on the pregnancy and the baby. And also one of the things that other people have not always considered is what happens if you have very severe uncontrolled psoriasis. What I showed you before is that it may actually affect your pregnancy outcome. So all of this, like this little teeter-totter shows, is a balance, and you have to figure out personally what you feel comfortable with, and your physician also does the same. So one of the things that the FDA does to help patients and physicians assess the risk of medications is grade the risk of each medication. The old system, which was developed in 1979, actually assigned one of 5 letters to pregnancy or to medications for pregnancy, and those would be A, B, C, D, and X. And I'll go over that in a second. They don't actually use this system anymore. It was phased out in 2015, and it was replaced with the pregnancy and lactation labeling final rule. So now if you look up medications that came to market or were approved before 2015, they'll still have these old pregnancy categories listed above, A, B, C, D, and X, and they're still referenced. However, new medications and all medications with a package insert will also have this new pregnancy and lactation labeling final rule, and it's just a narrative, like a long description in the package insert that gets divided into 3 categories: pregnancy, lactation, females and males of reproductive potential. And within these 3 categories, they actually summarize all of the literature and studies that have been done to tell you how safe or not safe or how lacking in information we are for each of the medications during these different time periods. So this is the old FDA system where you have pregnancy category A, B, C, D, and X. I'll start with X because the X are the ones that under no circumstances would you be recommended to take this while pregnant. Pregnancy category A means that there are very well-controlled studies and they were adequate in size to demonstrate a risk to the and they did not show any sort of risk to a fetus. There are very few drugs that actually fall into pregnancy category A, and there are none that are for psoriasis treatment. Pregnancy category B is where we tend to kind of say, okay, if something is A, it's safe. If something's B, it's probably safe. And they'll still recommend treatment with these drugs during pregnancy. And this is the one where no studies in animals have demonstrated a risk to the fetus, but there's no studies in humans to confirm that this risk does not exist. Pregnancy category C is, I think, where we kind of get on the borderline, where some people will give pregnancy category C drugs in certain situations because it's needed, but the actual definition of pregnancy category C is that animal studies may have shown that there's a risk, but there's still no studies in humans, so we don't know if this risk that we see in animals also exists in humans. And pregnancy category D means that there is evidence of human risk based on either studies that were done or marketing experience, meaning after the drug came to market, there had been reported cases of risk occurring while taking the drug. But these patients may still get this drug despite these known risks because they have no other alternative and they need it for their overall health. But again, the take home from this slide is to know that A and B is generally safe, C is kind of on the borderline, and D and X are usually not recommended to pregnant women except for under specific circumstances. And then here's more information about the pregnancy and lactation labeling final rule. So you'll see in the pregnancy category, which it includes labor and delivery time period, they'll have a risk summary of the medication. They'll have a pregnancy exposure, registry information, clinical considerations, data on pregnancy and the drug exposure. Lactation is for anybody who's nursing or breastfeeding. They'll give information about the expected risks during this time period with the medication, and then females and males of reproductive potential are people who are planning to get pregnant or having difficulty to get pregnant. This is where you'd find information about the medication from that perspective. So let's get down to the specifics of psoriasis treatments during pregnancy. So the first one is topical therapy. And I think a lot of patients are told topicals are harmless, but there are some topicals that do generate detectable blood levels. And this may have to do with the amount of medication that you're putting on your skin and the frequency. So if you put on a lot, very often, it's more likely that some will get absorbed, or the strength of the medication. If the medication is stronger or more potent, then it also will be more likely to be absorbed. But the other thing to think about with topical therapy is that women who have young children or who are pregnant, they may not have time to apply topicals. And specifically, once a woman has given birth and they're restarted on topical therapy, women have to be careful of where they're putting the topical medication, because if they're putting it on their breasts and the baby is breastfeeding and actually ingesting that medication, is more likely to be absorbed than if it was just touching his or her skin. So for topicals and psoriasis, you can see that all of them are pregnancy category C. There was a recent Cochrane review, which is a summary of all the studies that were published for topical corticosteroids or topical steroids in pregnancy, and they advised against using high-potency steroids due to the risk of low birth weight. And if you go to the psoriasis.org or the NPF website, you can actually look here at the topical steroid potency chart, but we do prescribe many high-potency steroids for patients who have psoriasis, and these would be like clobetasol, diproline or betamethasone dipropionate, halobetazole. Those are ones that are the most potent or class 1, and these are the ones that are usually recommended to be avoided during pregnancy. Calcipotriol or calcipotriene is pregnancy category C as well, and tazarotene is pregnancy category X, so under no circumstances should it be used during pregnancy. Phototherapy is often recommended for patients as well. There's no FDA pregnancy category applied to it because it's not a medication. It's considered a treatment, and often we consider it safe. There is one article showing that a lot of narrowband UVB or phototherapy may decrease serum folate levels in patients with psoriasis, and so you should talk to your doctor about doing extra supplementation potentially of folate, especially in the first trimester if you're on narrowband UVB. There's a type of phototherapy called PUVA, which is psoralen plus UVA. This is not recommended due to potential birth defects related to the psoralen ingestion or the medication that you take prior to exposure to UVA. The other thing to consider for phototherapy is that it's very time consuming. So unlike being able to take a medication and apply it or inject it or ingest it at home, you actually have to go somewhere to get the phototherapy done. And some patients just don't have time to do this while they're pregnant, and especially not in the early months after they've had a child. So systemic agents, I think, are the ones that are the most controversial during pregnancy. And I actually am on like a forum with a bunch of other board certified dermatologists, and someone recently posted, what would you do for a severe patient with psoriasis? How would you treat them? And it's interesting to see that there's quite a wide variety of answers. But what we know about systemic therapy is that some of the medications have pregnancy categories of C, X, nothing assigned, B. And so it appears that some are safer than others, but we'll go through the details of each right now. So methotrexate is considered pregnancy category X, and that's because methotrexate inhibits folate metabolism, which is required for fetal development. And folate is one of the medications that they recommend patients take as part of their prenatal vitamins. And if you have taken methotrexate during your pregnancy, especially in the early trimesters, one of the risks for your baby is a neural tube defect, and this can be detected on ultrasound. So if you had an unplanned pregnancy and you were exposed to methotrexate, it's good to alert your OBGYN so they can look on the ultrasound to see if there's any issues with your baby. Of note, methotrexate is also used as an abortant for abortions, and so that's another Some patients that are taking methotrexate are not able to sustain their pregnancy because of this. The recommendations for stopping methotrexate are about 1 to 3 months before you get pregnant. However, we know that most of it is cleared after just 1 week. For males, there's not a lot of studies on the safety of methotrexate, and it's not clear whether methotrexate really influences fertility or the sperm DNA integrity. There were some thoughts that maybe methotrexate altered sperm's DNA, which could lead to birth defects or difficulty getting pregnant, but they didn't find any actual increased risk when they looked at all the studies that were published, but they also noted that there are very few studies out there. Tofacitinib is relatively new, and that's why it has no pregnancy category assigned to it. It's only approved for psoriatic arthritis, and this is the only information that we have so far was one study of all the patients that were enrolled in the ulcerative colitis study. There were about 1,150 patients. Only 300 of them were women of childbearing potential, and of these 300 women of childbearing potential and the total 1,157 patients, there were 11 cases of maternal exposure and 14 cases of paternal exposure to tofacitinib either before or at the time of conception or during pregnancy. And you can see the outcomes down here. So of the 25 cases, 15 resulted in healthy newborns. There were no fetal deaths, no neonatal deaths, no congenital malformations, 2 people with spontaneous abortions, and 2 people who elected to terminate. And it doesn't say whether or not it was because they had drug exposure, but they just know that 2 terminated. And this is not that far out of line with the overall pregnancy outcomes that I talked about earlier, were about 15 to 20% of pregnancies result in either spontaneous abortion or elective abortion. So cyclosporin, which we use mostly for pregnancy flares, is pregnancy category C. It's been associated with premature delivery and low birth weight, but we have a lot of data on it because it's used in kidney transplant patients. And even though there are some comorbidities such as hypertension, preeclampsia, and gestational diabetes that they see in patients who are treated with cyclosporin, they are not sure if this is due to the drug or the fact that these patients who are mostly transplant patients, such as kidney transplant patients, also have this as an underlying comorbidity. And then acitretin is pregnancy category X. Many people only prescribe this to postmenopausal women, and the reason for that is because you have to wait 3 years after you've taken this drug to become pregnant because it stays in the body for a long time. And they know that acitretin, which is similar to isotretinoin, has a high risk of spontaneous abortion and congenital malformation when it's taken during the first trimester of pregnancy. So this is definitely a drug to avoid. And then we get to the biologic agents, which, as I said before, over 25% of psoriasis patients are now taking. What they know about biologic agents is they're pregnancy category B. And the interesting part about them is they've done studies looking at how much of the biologic agent gets into the umbilical cord blood, which is what exposes the baby. And we really don't see a lot of patients having high levels of the medication in the umbilical cord blood until after the second trimester. And that's because there's actually a mechanism where the placenta transports this type of medication across from the mother into placenta, but it doesn't become active until the end of the second trimester of pregnancy. So because of that, with the anti-tumor necrosis factor or the anti-TNF alpha drugs, we really consider them to be safe during the first half of pregnancy. And if you look at the rheumatology and the gastroenterology literature, the Canadian Gastroenterology Society, for example, encourages patients to continue taking biologic agents that are TNF alpha inhibitors until week 22 of 24 of pregnancy. But for those patients that are very severe, because they know having very severe inflammatory bowel disease can have adverse effects on pregnancy, they weigh the risks and benefits, and they actually recommend treating all the way through pregnancy for very severe IBD patients. Rheumatologists, some of their guidelines suggest safely continuing therapy until week 30 of pregnancy. Of note, there are no guidelines and that rheumatology is for rheumatoid arthritis. There's no guidelines currently for psoriasis or psoriatic arthritis. So the other thing to note is that not all biologic agents are the same. There's two specific ones, certolizumab, which is Cimzia, which is approved for psoriatic arthritis and recently got approved for psoriasis, that actually can't be transported across that receptor. So a lot of people will consider this the safest drug to use of all the biologics during pregnancy because it doesn't go to the placenta and the exposure to the baby is minimal. Etanercept, which is another TNF alpha inhibitor, is also considered to be safer than adalimumab or infliximab because the shape of its molecule is also larger and therefore it's transported less frequently as well. And so one of the things that we see is, oh, it's pregnancy category B, but is it really safe? They now have studies, 4 studies in total of over 1,300 women who are exposed to TNF alpha inhibitors 3 months prior to or during the first 3 months of pregnancy. And they found a slight increased risk in congenital malformations in 3 of the studies and an increased risk of preterm birth in 1 study. But the limitation that they noted is that they didn't look at these patients and adjust for what other medications they were on in addition to the biologics, because some of those may have impacted the risk. And they also didn't look at disease severity to see if these were the most severe patients or not. And they said overall there was no specific pattern that they could discern to figure out who would be at higher risk than others when exposed to TNF alpha inhibitors. And I know we're running low on time, so I'll just, if there's questions, I can show the specific slides about the other biologic agents, but most of our data so far is on TNF alpha inhibitors. We have very little data on the IL-17 inhibitors, which are Cosentyx and Taltz, and the IL-23 inhibitors, which are guselkumab or Tremfya, and tildrakizumab or Ilumya, and Stelara. And the reason for this is that they have fewer indications. Most of them were developed as psoriasis drugs, and so we don't have as much data from inflammatory bowel disease patients and rheumatoid arthritis patients who took them. And these are also much newer medications than Humira and infliximab or Remicade and Enbrel or etanercept that came out over 15 years ago now. And this is an article that I wrote in 2017, but if you wanted to look it up, it goes through all of the literature. And one of the things I'll note is that there was very limited data for all of the new agents. But in the last few years, we have more information about ustekinumab. So this is 87 reports, so 55 patients prospectively, meaning they followed their pregnancy, and 32 who reported it after the fact, who were exposed to Stelara within 2 months prior to pregnancy. And you can see that there was really no difference between live birth, spontaneous abortion, elective abortion, and congenital anomalies between the general population and the Stelara exposed patients. And then ixekizumab as well, which is Taltz. This is another poster that was presented, but you can see that there are no congenital abnormalities reported in any of the people who are exposed to Taltz during the first trimester. And tildrakizumab as well had very similar outcomes. They had, in their phase 3 trial, 10 pregnancies were reported, and they had 4 cases of fetal loss. 2 were spontaneous abortion, and 2 were elective abortion, and 6 full-term live births with no anomalies. And then secukinumab, which is Cosentyx, you can see this is from another study where they looked at the data. There were 238 patients, but over 119, so more than half, were lost to follow-up. But again, they did not have, most of them resulted in full-term births with a very low rate of congenital malformation. And then just briefly, if you do get pregnant and you are treated with a TNF alpha inhibitor through all of pregnancy, they recommend no live virus vaccines in the first 6 months of life, and the only one this really applies to in the U.S. is rotavirus, which is administered at 1 month of age. But it's because it takes about a year to clear biologics out of a baby's system. And there was one report of a 28-year-old mom who had a healthy infant. She was treated with infliximab throughout her pregnancy. She was given BCG, which is a vaccine that they give for tuberculosis, at 3 months of age. And the baby died of disseminated BCG, meaning that it had spread all throughout her body. And so that's where this recommendation to not give live virus vaccines came from. And then for breastfeeding, just so you know, there's very few studies on breastfeeding, and one of the things that we always weigh the benefits of are if a patient can get formula, should they just use formula instead of breastfeeding? But there's a lot of good studies on the benefits of breastfeeding, so it's a very personal decision for parents to weigh on whether or not they want to breastfeed their children, regardless of if they have a disease or not. But things that affect the infant blood levels of medications are the transfer in the breast milk, if the mom's exclusively breastfeeding or partially breastfeeding, the timing of the feeding. So when you take a medication, it reaches a peak level in your blood, and then it has to be excreted, and it can go into the breast milk. So sometimes, for example, if you take a medication and then you breastfeed immediately afterwards, that drug probably hasn't had a chance to get to the breast milk yet. The age of the infant matters because of their size, and then there's variable GI absorption. So even though it may be in breast milk, it goes into the infant's stomach, and it sometimes can get broken down, and so then it doesn't actually get absorbed, and you might not find it in their blood. So in terms of TNF-alpha inhibitors, we find there's very little secreted in normal breast milk because they're very large molecules and they don't transfer well, and that most get destroyed in the infant GI system or in their stomach, and they're not absorbed systemically. And they've done some studies of women where they looked at their breast milk, and they found that a small percentage of them had the medication in their breast milk, but when they look at their outcomes between babies who are breastfed by mothers who are on TNF-alpha inhibitors versus babies who are not breastfed, they had the same rates of infection, and they reached their developmental milestones at 1 year at the same rate. So they didn't really find that this impacted either infection or development. And then just the last slide, which is if you have any questions specifically, there's this mother to baby website, and you can go up here and you can search in the box and type in the medication, and they'll give you all the information on the studies. You can also call them and you can report if you've had any exposures or if you have any questions, and they'll give you brochures and answer them for you. So that's all.
Terrific. Thanks, Dr. Porter, for such a great and informative webinar. We really appreciate all the information you provided about planning during and after pregnancy with psoriatic disease. It's now time for the Q&A portion of this webcast. If you have additional questions, please place them in the questions pane on your attendee interface now. We'll attempt to answer as many questions as possible in the remaining time. Dr. Porter, the first question that we will ask, you had mentioned something about flares earlier. What can be done to prepare for or minimize postpartum flares?
Yeah, so I think the best thing to do to minimize postpartum flares is have a plan during your pregnancy for what you would like to do postpartum. And that plan would include deciding if you want to immediately get back on medication, if you have stopped it, if you want to treat through your entire pregnancy, because staying on treatment during the pregnancy will minimize postpartum flares afterwards, and then deciding in advance if you think you want to breastfeed or not, and then discussing with your dermatologist, your rheumatologist during your pregnancy so you have a plan of when you would like to start medication. And usually they know that in the first 2 to 3 months after pregnancy, people kind of stay as they were during pregnancy, but it's when you hit that 2 or 3 month mark that the disease really starts to act up again, and that's as your immune system is going back to normal. So you have a little time to decide, and a lot of mothers will choose if they want to breastfeed but not expose their babies to any sort of medication to breastfeed and pump milk during those periods and then restart the medication right afterwards. But I think having a plan with your doctor is the best thing to do, and knowing what you feel comfortable with.
Okay, great. Here's a related question. If I flared after my first pregnancy, will the same thing happen after my second?
We usually think that the same pattern occurs with every pregnancy, but there's no guarantee that if you flared or you didn't flare the first time that you won't the second time. It's just that we tend to think that your pattern will be the same with every pregnancy.
Okay. On a different subject, should my dermatologist or rheumatologist be speaking with my OBGYN about my treatment? And how can I be sure that I'm making the right decision for both me and my baby?
Yeah, I think your dermatologist or rheumatologist if you're considering using any medication that is not just a topical, they should be involved with you from the time that you decide that you want to get pregnant. And most OBGYNs are very good with communicating with the dermatologist or the rheumatologist, but most of them also tend to try to limit any sort of exposure. So your dermatologist or your rheumatologist and you as the patient will really need to advocate for yourself if you want to take a medication during pregnancy. But I've had many OBGYNs, once the patients express how much the disease impacts their life, they're much more willing to be more aggressive during pregnancy. But you yourself, and hopefully this session has helped, to really need to understand the risks, because as a mother myself, I remember the first time I was pregnant, I was afraid to take anything or apply anything to my body because I didn't want it to impact the baby. And the second time I was pregnant, you realize how likely it is that your baby will be fine, and you're a little bit more lax with everything that you do.
Okay, terrific. So kind of moving earlier in the cycle, when should conception be attempted? Should a patient wait until in remission or off a biologic, even though it may advance maternal age?
Yeah, so I think that's one of the most difficult questions is if you're already getting older, the longer you wait, the harder it is to get pregnant. So if you're not 22 years old and very fertile, anything over the age of 28 makes you, your fertility has decreased, no matter if you have psoriasis or not. Like I said during my presentation, biologic agents really aren't transported across the placenta until the end of the second trimester, and we really do consider them to be safe up until at least week 22. And like I said, GI people will stop 22 to 24 weeks. Rheumatologists may stop at 30 weeks giving the medication, but there should be a discussion with your dermatologist or your rheumatologist that changing to biologic agents that are less likely to be transported across the placenta, and that would be number one, Cimzia, which has almost no transport, and the second would be Enbrel, which has some transport, but much less than Humira or adalimumab or infliximab, for example.
And are cortisone creams dangerous if applied on the stomach?
So the location of where you apply your creams matters in the sense that thinner skin is more likely to get absorbed. So a lot of times your dermatologist will say, don't apply this to your face, don't apply it to your armpits, don't apply it to your genitals, because those are the areas where the skin is thinnest. Your abdomen skin doesn't actually thin out. It gets a little stretched when you're pregnant, but the risk of absorption applying to your belly versus applying to your leg is probably about the same. As I mentioned before, the recommendation is to avoid very potent corticosteroids topically, which are the class 1 and class 2, like clobetasol and betamethasone, and go with more milder steroids. And you can ask your dermatologist which ones those would be, and you can look on the NPF's website because they have the best chart actually of anyone I've seen. But like I said, lower potency and mid-potency steroids, although pregnancy category C, are thought to be safe during pregnancy.
One last question, and then we'll talk about some resources. Does psoriasis sometimes occur on areas that were stitched after a vaginal delivery, or is it strictly the Kebner effect only on C-sections?
It can happen anywhere that you traumatize the skin. So it could be if you get an IV, for example, you can get it around the IV site. You can get it in the vaginal area as well, but it's a little bit less likely for psoriasis to develop in the vagina versus on the labia or the vulva, because the skin of the vagina is actually different lining than the skin that kind of touches the outside air, for example. And so the vaginal skin shouldn't really develop psoriasis, but if the tear extends outside and it's on the skin that you can normally touch, where you have hair, for example, in that area, then you can get that same Kebner phenomenon down there as well.
One more question. Are there any extra vitamin supplements I should take to help the immune system, or just stick to the basics, folic acid, prenatal multivitamin?
Yeah, so we always tell people to discuss with your OB too, because many of the supplements, for example, have things that are not good for babies in them. I would recommend sticking with folate, definitely. But anything else beyond that, I would ask your OB. I wouldn't take any sort of medication that's thought to be anti-inflammatory. That's a supplement, because those actually are never assessed by the FDA, and so we don't have very good data. And even worse, with supplements and vitamins compared to medications that are approved for pregnancy. So I'd avoid them unless you've already talked to your OB about them.
Thank you so much, Dr. Porter, for sharing your expertise with us. We really appreciate your time today. You can continue to learn more about pregnancy and psoriatic disease through the Psoriasis, Psoriatic Arthritis, and Pregnancy booklet by visiting the Foundation's website at the URL listed on the screen or contact our Patient Navigation Center. If you still have questions or would like to receive additional information about treatment options, find a physician, or are having issues with accessing treatments, please contact our Patient Navigation Center by phone, email, live chat, or Skype. Once you leave today's webinar, you'll receive a survey to provide feedback about the presentation. Tell us what you think. We value and appreciate your comments. I'd like to thank again our sponsor, UCB, for their support of today's webinar. Tomorrow begins Psoriatic Arthritis Action Month, which will feature a number of activities and information which can be found at the website listed here. Here's a list of webinars specific to psoriatic arthritis. Please look for an email announcement soon, which will include registration links. Finally, you can access our webcast archive at psoriasis.org/webcasts. This concludes our presentation today. Thank you for attending.